Okay, well, this was a great session. We have time for a few questions. I'd like to have all the speakers sitting up front here, and we'll go ahead and have a few questions. Actually, I really enjoyed the last paper, Natalie. In Vail, what we've been doing for a while is we always do a single leg functional test before and after surgery. And for us, that's part of our functional sports test. I think you're onto something there. I think it's very important to retrain these muscles, and it's a very good prognostic indicator for return to high performance. So it's interesting to see that's validating. We've been doing this for 10 years, and that single leg test for us is very, very predictable of a return to play.
It's certainly something that's been looked at a lot in the patellofemoral pain group, and what they've shown is that strength training alone doesn't change the way that you move, but functional retraining does. So I think sort of going on, if we are looking at RCTs or clinical trials of interventions for hip arthroscopy, that should definitely be included.
I just have a question also to follow up on this. When we do our impingement surgery, do we change the torsion of the femur, which might affect the actual distal? Because when we remove the cam, we actually change the sitting position of our femoral head by a few degrees because we restore the normal offset. So anybody in the panel has a follow-up on that and saying, if we change the actual natural resting position of the femur in a single leg stance, do you think it will have an impact on the muscles because we change actually the position by a few degrees? Let's start with Femi here. What does he think about this?
Thanks, Mark. I think this is a great idea for a study. Okay. I don't think we have the evidence to tease it out. I think biomechanically it makes some sense, but I think we need to evaluate that, looking at muscle function and correlating that with bony morphology.
Damien?
I don't think that we change the torsion of the femur. I mean, the femoral head is still in the same place, and the axis of the shaft is still in the same place, and the knee is still in the same place. But what we do is increase the head-neck offset, and so we create more space between the front of the neck and the anterior rim of the acetabulum. And I think we can sometimes do that deliberately because there's not enough anti-torsion of the femur. But when we do it, it seems to me that we create a part of the range of movement that the patient has never been in before. And so presumably they don't have the muscular programs to control their hip in that position. So I think if we are going to do that, a very important part of their rehabilitation should be to deliberately take them into that space and train them to use that new bit of the range of motion.
Great, thank you. Go ahead, John.
I agree with everything that's been said, and I think the other things that we need to consider are that we know that when you intervene arthroscopically, you can have a significant positive effect on patients' pain. We also know that pain has a large impact on the ability of muscles to function normally, so I think we need to look at the relationship with pain and muscle function. And I also think in terms of future studies, we need to consider biomechanics in functional positions, not just gait studies. There have been a number of gait studies that have looked at gait in this population, but I think as a clinician, gait is the thing that hurts the least for these patients. We should be analysing their biomechanics in functional tasks that are problematic for this particular group as well.
Richard?
Yeah, I often say to patients that a muscle will only be 100% strong if the joint it serves is 100% normal. And as Damien has already said, we're giving back these patients, at the very least, an improved range of movement. So there's a whole muscle group, world of muscle activity, which is as yet untested in that individual. And so there's bound to be muscular changes without any doubt.
Oh, yes, Dr. Myers.
Yeah, great talks, and I'll direct this question at Ricky, but I think that the rest of the panelists are more than qualified to answer this question as well. And it has to do with the definition of instability, and there's a continuum of definitions out there, it seems, and a continuum of other things related to hip instability. And I certainly there are the folks who have the sensation, the woman usually, of the head popping out anteriorly as they're walking, and it's a really painful sensation. And we'd all call that instability, I think. And I unfortunately see a lot of those post-hip arthroscopy that come to me thinking that it's a muscle issue, and it is, in fact, a way to fix it to some degree by fixing the muscles. But can you give me a perspective, or give us a perspective on how we should be using that term, instability?
I knew you'd ask me an impossible question, Bill. Yeah, sure. The understanding of instability is relatively primitive. The testing of instability is even more primitive. That's my understanding of it. And that most of the tests of instability we do, are based on putting the hip in certain positions of stress and trying to replicate pain, as it were. And it's difficult to know, without looking inside that hip, whether there's something else that's likely to be causing pain. So instability is, as you highlight, a whole spectrum of things. And it's very, the number of patients who turn around to me and say their hip doesn't feel. I ask every patient, does your hip feel it's in the right place? Most don't quite know what I'm talking about. Most will then take a step back and think, well, maybe there's something in what this guy's saying. And clearly, the extreme instability is beyond obvious. But those shades of grey in the middle are very, very difficult to define. They really are. So I haven't answered your question, other than just to say it's impossible to answer for me.
Yes, Christian Thorborg from Copenhagen. What a brilliant session. Thank you very much, all the speakers. I have a question for you, Natalie, and your talk. Is because in the literature, there's actually a few studies who's shown in the same lines as you, that's actually increased medial displacement and increased internal rotation is actually related to increased strength. So I was a little surprised that you were surprised with that finding. But do you have also in this, was there a control group as well? Because couldn't this just be related to the way they move?
Do you mean a control group for the... Okay.
Yeah, a group without hip pain.
For the hip, the dynamometry measures?
No, yeah, also for that, but for the relation between the way they move and the strength measures. So was that only in a group with, who had pain?
We only looked at the relationship in the hip arthroscopy people because we thought that was more meaningful as a clinical question. We do have that data as part of Joe's cohort, so it's something that we could look at.
Because my point is, I think you would probably see the same in people without hip pain.
I have a question for Per here. When we do a correction, I kind of misspoke earlier, do you see a lot distally patellofemoral problem after impingement surgery? Because dynamically we change our rotation a little bit internally. So does it affect the distal femur at the intercondyle groove with the patella? Do you see, especially those with VMO atrophy or weakness, do you see any more change distally after impingement surgery due to muscle imbalance?
Yeah. You doing 10 times more hip arthroscopies than me. It's funny to address that to me, but yes, I'll try to say I don't think I see that very much. I think I know what you mean. I can see the point. It could be something that would happen when you do this, but it's not my experience that this happens after.
Yeah, I see it once in a while, and I'm trying to understand it, and that's why I'm very intrigued with the single X test, and I think it was a great study. So I know you're an expert in that area as well, so I was just curious to have your opinion. Anybody on the panel has seen that also in their practice? Distal patellofemoral problem after correction of impingement, especially after large correction of cam impingement? We'll start with Femi.
No, Mark, not commonly, but I think if you look at the risk factors for patellofemoral disease, which typically are weak abductors, weak hamstrings, valgus alignment, pes planus, if you do put your portals right through your flexors and abductors, you can weaken your abductors and then obviously trigger in the valgus aligned patient somebody you can present with patellofemoral disease post-intervention. So I think it's the constellation of risk factors for PF disease, patellofemoral disease, when you perform your arthroscopy, you can accelerate that presentation by weakening the abductor, specifically the lateral portal.
Thank you. I haven't seen it after arthroscopy, Mark, but I have seen it after femoral rotational osteotomy, which I think is probably the same mechanism as you're thinking about. And I guess this should just emphasize to us the point that Joe and Natalie have been making, that we can't just operate on the bones. We're going to have to treat the whole musculoskeletal system.
Mark?
What I tend to see is that these people have patellofemoral pain preoperatively because of all the changes in the mechanics, and that often it's still there postoperatively and needs to be dealt with appropriately.
Yeah, Hassan has a question up there. Yeah.
Actually, I've seen that also, like in your experience, these patellofemoral diseases. My point is, I also do joint arthroplasty, and you see that also after joint arthroplasty, these patellofemoral diseases. I think we have a subcategory of FAI patients who have a small flexion contracture at the hip joint, and when we correct the FAI joint, they go into more extension. And the quadriceps tendon and the psoas tendon are probably a little bit shortened. And you correct with time the psoas component, but the quadriceps component takes more time. So I now insist more on quadriceps stretching, and that helps a lot, that component. But I've seen it also in the subgroup of young arthroplasty patients, and that's why I've gone in that way.
Thank you. Yeah. Okay, one more questions. Yeah.
First of all, compliments to all speakers. Excellent talks. My question is for Damien Griffin, and it's regarding the quantification of cam deformity. So you suggest to measure the alpha angle in the somewhere between the 12 and 3 o'clock position. But I think we also have to acknowledge that the measurement of the alpha angle has its limitations regarding the reproducibility. So the more measurements you do, the higher the risk of falsely positive measurements. But on the other hand, if you do only 1 or 2 measurements, you have the chance of missing a cam deformity. So what would you suggest? How much measurements you would do and in which planes?
Can you hear me? Yeah. So I think there's a difference between epidemiological research and clinical practice. So in clinical practice, if I'm faced with a patient who I think has got hip pain, then I'm quite comfortable to do a fairly extensive set of measurements. So we use radial imaging, and that would give me 12 measurements around the circumference of the head-neck junction. And usually one's only interested in the sort of 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock positions, although sometimes outside of that. But if we were going to do an epidemiological study, which is what I'm implying we need, and I know you would agree with me, across general populations, then we're going to have to think quite carefully about what we're actually going to define as abnormal. Because we probably shouldn't be defining simply an AP radiograph. I think there's some issues about just using a lateral radiograph, and we've got some evidence that if you just use an AP radiograph, you miss about 60% of the cams. If you use a lateral radiograph as well, you probably still miss about a third of them. And so perhaps we do need some sort of reconstructed cross-sectional imaging, which then becomes expensive and difficult for epidemiology. For me, perhaps the most exciting possibility is that we could use ultrasound for epidemiological screening and make one measurement at a 1:30 position with ultrasound. But that's still being developed.
Thank you very much. Great talks, all the speakers. Great session, and we'll reconvene at 11 o'clock after the coffee break. Thank you very much.